Okay, so now let's talk about drugs, and this is probably the most controversial part of the course and the place where there's the biggest sea change in the management of emergency airways. So let's talk about the pretreatments. Anyone still use any of the pretreatments? Come on, some of you use atropine for kids, I know it. Raise your hand. Who is it? Who still uses atropine? They're not admitting it. So this is, and I used to have the nurse take the lidocaine, go out into the, outside the hospital to the ambulance gurney and give the lidocaine to the patient as they drove up, because you're supposed to wait something like 2 minutes from the lidocaine, and then I'd give the fentanyl dose, then I'd give the half dose of Sux. I mean, this was ridiculous. It was so complicated, and fortunately, none of these have been shown to be of any benefit in managing the patients. So atropine, I throw an extra slide in here because some people have an attachment to atropine. So atropine is dangerous. It should not be given, because what is the sign, the most ominous sign of hypoxia in an infant? Bradycardia, right. And so by giving atropine, you're potentially masking that, and you're not going to know that your baby's about to code because you masked it with the atropine. So it's no demonstrated improvement in outcome. What do you, in your pediatric fellowship, are they using atropine? No? Okay, good. So none of the pretreatments help. Don't use any of them. RSI is complicated enough and task saturated enough. We don't need to add any unnecessary steps. Okay, so now let's talk about sedation. Anyone use ketamine as their #1 sedative? Just Lorena and I? Okay, so 100 of ketamine, you know, I try to simplify it. You know, if you're an adult, you get 100 of ketamine. If you're a kid, then I figure it out based on your weight. Etomidate, everyone else uses etomidate? Okay, anyone use propofol? Sometimes? Yeah, I mean, the one slick thing about propofol is that if they're not hypotensive and they're not an MI patient or CHF patient, you give them the bolus and you've already got your drip right there, and it's kind of slick just to basically continue the same medication. So I think we're all familiar with this. They all, onset's about the same, somewhere 30 to 60 seconds. Duration, etomidate probably the shortest, and ketamine the longest. So etomidate, so if we talk about what is the perfect agent would have no hemodynamic effects, it wouldn't affect ICP, there'd be no contraindications, and no adverse outcome for any different disease pattern. And etomidate really was the perfect drug for us. There was a bit of a controversy about it years ago affecting sepsis patients. Hopefully nobody's hearing that anymore, because it was definitively shown that there's no change in outcome for use of etomidate for septic patients. Excuse me, the only thing that changes is it screws up the cosentropin stim test, which used to be part of the sepsis pathway and has now been removed. So it's really a moot point now. So etomidate is essentially every patient, etomidate can be an appropriate choice. Adverse effects, it can cause some pain on injection, but they're not going to feel it, and myoclonic jerking. And I use etomidate almost exclusively for cardioversion. It's my favorite drug for cardioversion. And what's odd is the spouse, for some reason, always wants to watch their partner get shocked. And I always offer they can step out of the room, but no, they're always like, no, I want to stay and watch. So I warn them about the myoclonic jerking. I said, because I don't want them to freak out when they see their loved one jerking. So ketamine. So ketamine is, I use ketamine now essentially exclusively. The nice thing about ketamine is it gives a little sympathetic kick. So somebody that's hypotensive or septic, ketamine may be the drug of choice to basically improve their hemodynamics. Everyone knows it's a bronchodilator, so we've all kind of in the back of our heads thought about that it's the drug of choice for COPD or status asthmaticus. What I really like about ketamine is you get analgesia. I mean, no matter what you're getting intubated for, you're probably experiencing some level of pain. That's probably driving some type of catecholamine drive. And you're getting amnesia. And one of my attendings at Highland remembers getting intubated when he was hit on his bicycle. And some people talk about serious psychological downstream consequences of that experience. So I think amnesia, if I get intubated, I don't want to remember it. So I like the amnesia, I like the analgesia, and here's the important thing is there's no effect on ICP. So ketamine was kind of out of our toolbox for a number of years because there was this concern about if somebody had a traumatic bleed that it would make it worse. And there's a couple nice summaries. Subsequent to this study from the Canadian Journal of Emergency Medicine, there was 2 articles in Annals and an editorial essentially saying, ketamine is either neutral or beneficial for cerebral perfusion pressure, and there's no contraindication to its use in head trauma. The only contraindication to ketamine is somebody you suspect has a hypertensive bleed. So if somebody comes in altered and the pressure's through the roof, there's a potential that the ketamine will elevate their blood pressure and potentially extend the bleed. So, but in the traumatic patient and all other patients, you really don't have to worry about ketamine. So that's the only time I avoid ketamine. All right, ketamine, it can cause laryngospasm, but who cares? We're paralyzing them. This will be an issue, though, when we talk about sedated intubation. Oral secretions, I don't know if you guys have seen it. I really haven't noticed it, and I use ketamine quite a bit. Yeah.
So my big issue with ketamine is we used it all the time in Africa for awake
Right.
intubations. And when they had laryngospasm, we did not have a paralytic 9 times out of 10 to go to. So is there anything else you could do besides a cry?
Yeah, there is. Actually, this guy in Australia published a series of papers. There's actually a maneuver you can do, and we'll talk about this. Yeah. So basically, if you take your thumbs under the angle of the mandible and lift up in that painful spot there, that breaks the laryngospasm. And so, yeah, that would be helpful to have in Africa. Okay, propofol. It's cool if they're not hypotensive, but propofol is a cardiac depressant, a myocardial depressant. So you want to avoid propofol in your CHF patients and your cardiac arrest patients. So it's not a good choice for post-intubation sedation for those patients. You want to use Versed and fentanyl or some other combination. It decreases cerebral perfusion pressure, so you want to avoid it in patients that you think have a stroke or space-occupying mass. And it's actually soy allergy, not egg allergy, that's the issue with propofol.